so that anybody who can't be here for this will be able to view this, and will be able to realize any mistakes that I've made, or if I cough or sneeze. So, Department of Juvenile Services. One thing I did want to emphasize is that when we talk about the juvenile justice system, we know that it's not just DJS. We are controlled and impacted by federal and Maryland legislation. We interact with education, with behavioral health, and with child welfare. And behavioral health really is a broad term that has to do with mental health and with substance abuse. And I should be updating the slide really to include the whole health department, including DDA, because we really are forging some new partnerships. So in Maryland, Maryland is kind of unique among a smaller number of states that has a juvenile justice agency or department that is statewide. Many other states have local detention, local probation, and then a statewide youth authority. In Maryland, Department of Juvenile Services has everything from intake through aftercare with treatment planning throughout. In Maryland, the courts determine whether or not it's safe for a youth to remain at home or is in need of out-of-home placement, and the court is responsible for ensuring the youth's needs are met. And this is important because in some other states, once a youth is committed to a juvenile youth authority, the court's involvement is finished. In Maryland, that's not the case. Our courts review the youth while they're in placement. We're part of the Title IV permanency planning, along with child welfare. So the court is involved even after a youth is committed. I'm not going to read to you the vision and mission. Oops, sorry, I went way ahead. Oh yeah, okay. So I'm not going to read this to you, but I think the key thing to, I guess, remember for us is we are public safety. We work with youth and their families. We really, our primary role is public safety, and within that, then what are those factors that we need to influence to help public safety and to impact on recidivism? We do collaborate, obviously, with the youth and families and other agencies. That is our vision and mission. And successful youth, strong leaders, safer communities. The strong leaders are obviously the youth that we're hoping to impact. Hallmarks of the developmental approach. Our department is part of a reform effort that's been going on for several years. And this is really going to be supported with the reauthorization of the federal Juvenile Justice Delinquency Prevention Act, which is very much supporting the idea that we want to hold youth accountable for their behaviors without criminalizing and forcing them into further penetration into the criminal system. We're looking at confinement only when necessary for public safety. Disparate treatment we're going to talk about a little bit later, and family engagement. So, but you can review this and see that there are some really good publications that are available about the whole developmental approach. So Maryland's Juvenile Services has regions, and surprise, surprise, the regions for each agency never match up. So our regions look different than DDA's regions and so forth. And yet we still can work together. I think the local care teams really are a good mechanism for that. So this gives you a picture of where our regions are.
Actually, your regions actually match up with the regions.
That might have never happened before. I'm so proud. I'm so proud. So our facilities that we have detention facilities across the state, and this is the list of those detention facilities and where they're located. And detention is very different than commitment. Detention is a temporary holding of youth who would be a risk of flight or a public safety risk. Are there kids in detention who don't meet that criteria? Absolutely. We need to work on some myths about detention, that it's not respite, that it's not treatment, it's really a holding, and that we really do not want to have kids in detention unless they absolutely need to be there. Our committed facilities, we have staff secure, and staff secure means 24/7 eyes on supervision, and if you try to leave, we stop you. If you continue to try to leave, you're probably going to end up in a higher level of care. And then hardware secure. Hardware secure means a physical barrier, could be a fence, could be that you're in a locked building where the only outside area is maybe an enclosed courtyard, and this is the list. You'll notice that Savage Mountain Center is on the list of hardware secure programs, and that's a change. We took Savage offline temporarily, did some physical plant alterations and some programming alterations to make it hardware secure based on the needs that we saw for our population, particularly kids that were not successful in the staff secure setting of the youth centers and had some additional mental health needs and tend to be younger. So what's the scope of the population that we serve? I love this chart, and it is in our data resource guide, which I love to advertise. On our website is a data resource guide that we publish every year. And I always try to say this in a way that encourages people to read it. I used to say, if you can't sleep, you're going to have insomnia. And then people thought, well, does that mean it's going to put me to sleep? No, that's not what I'm saying. Just if you have some time, go on our website, take a look at our data resource guide. It's got a lot of information, a glossary, lots and lots of data. But this chart, I think, busts some myths about juvenile services and juvenile court. And it shows that of the large number of juvenile complaints that come to us, which are almost always police reports, so a youth is accused of committing an act that would be a crime if he or she was an adult. These complaints come, and most of the kids who get in trouble don't come back to us. We are able to use diversion. We're able to link kids to services, to have some sanctions at the beginning. And it's very important in our system to divert low-risk kids because we actually can do harm if we continue them in through the system. So if you look through authorized petitions, court dispositions, probation, and committed, in this particular fiscal year, which was fiscal 17, 5.2% of those referrals resulted in actual commitment. And the updated data for this year is about the same, 5.3%, although our complaints have gone down. Oh, thank you. And so our probation orders have declined, our commitments have declined, and this is part of a national trend that's been going on, that actual delinquency complaints have declined nationally, so Maryland is not alone. We'd like to take credit for it, but the credit goes to really some correction in the over-arresting and zero tolerance that was occurring in the late 80s and early 90s, and then some work that the sister agencies are doing in the arena of child welfare, in the arena of education and behavioral supports, in the growth and strengthening of mental health services for children and adolescents. And then we are really, really focusing on objective risk assessments and trying to divert those kids that can be diverted. So we're hoping to see some continued decline. And what does that mean? Then it means that the kids who remain and come through the system are going to be those kids who are the higher risk, higher need kids. And they'll need really good programming. So let's talk about our system of risk assessment and needs assessment. We do have a comprehensive integrated system. It's called the Maryland Comprehensive Assessment and Service Planning, MCAS. And this has been developed and researched and is continuing to be validated through the University of Maryland. And the way that we use this is to have objective, research-based items that we look at so that we can have a sense of objectivity and fairness. Our system involves a community intake risk assessment, and then as kids maybe penetrate further into the system, and they're court involved, we have a more comprehensive risk and needs assessment. That results in a supervision and treatment plan that is pre-populated and integrated so that our case managers don't have to start from scratch when they're developing treatment plans, and then needs reassessment. What is this built on? Obviously, we have to engage the youth and the families. We have to use motivational interviewing. None of these things can be accomplished without relationships and being able to have accurate information and assessment. Using standardized assessments helps to have more objectivity. Using individualized treatment planning says, hey, we're going to use some objective information and then customize it to this youth. We're looking at building on strengths and matching kids to evidence-based programs, and then coordinating and monitoring services. I'm going to talk about that a little bit more. And then using graduated sanctions and incentives. So this is something that Maryland has developed over the last couple of years that other states are looking at. And it really is this idea of having fairness once kids are in our system and are being supervised. They get a lot of surveillance. And so we have to look at how do we respond, because they're kids. So, and I say kids, and I must start saying children and adolescents, because I've been chastised, but I say kids affectionately. Kids encompasses even my nephews, and one of them just turned 50, but anyway. So this accountability and incentive management, the idea is to really have some fairness and consistency across jurisdictions and across case managers, so that when kids have make errors, we look at how significant are the errors. Are the errors associated with what their offenses were? And to have a chart of suggested incentives. And I have to say that for the first time in the last few years, we've actually had funding for the incentives. You know, we talk about, oh, you got to do sanctions, but you got to do rewards. But we've always funded the sanctions. Well, now there's some funding available to have rewards for kids and involve the kids and the families in determining what is going to work for those kids. So what's this resulted in? We're really trying to look at kids who get committed as the result of involvement with us, you know, not as a result of new offenses, and trying to really reduce the number of kids who get committed because they've made violations in their supervision, especially when it's behavior that's kid behavior, that's child and adolescent predicted behavior. We just happen to have them under high surveillance. So we're starting to see a decline. We involve the courts in this so that we would have the support of the judges and magistrates in trusting us to try and provide graduated interventions rather than just automatically having them come back to court and have the risk of removal from home. So one of the areas that really has helped and really is an integral part of what we do with kids once they're involved with us are these linkages to community resources. The local management boards, very, very important to us. Core service agencies are a big part of this because what's happening is we are, when kids are coming into contact with us, finding out through our assessments what their needs are. We look at criminogenic risk factors, and some of the criminogenic risk factors, meaning those specific factors that would predict recidivism, really cross over with mental health and other needs that are there. The local addiction authorities, really looking at how do we use the best practices in intervening with kids that we discover have substance use issues. And we're talking about primarily kids who use marijuana, although we do have some kids who are involved with opioid dependency. Obviously, the big problem, societal addiction issue now is with adults, and the overdoses are occurring in the older population. However, our children and adolescents are exposed to all this, so we have to make sure that we use our partners and make sure we direct kids into the appropriate services. So when kids are at risk, when children and adolescents are at risk of removal from home, here's where we're getting into those services that we are paying for and those services that are designed for youth who are at risk for removal or definitely going to be removed from home. So how do we do this? We have placement decision-making that involves our case managers and supervisors. We have multidisciplinary assessment and staffing teams. This has been a very helpful process that's been built over the last 8 years to really have clinical staff and have some objectivity and cross-discipline assessment and contribution to decision-making. Our resource office, central and our local resource offices are the experts in finding out what do we have that meets the needs that are identified, what can we drop from our array, and what do we need to add to our array of services. And then our central review committee is a process of looking at kids who are being ejected, so they're not being successful in residential care. Rather than just having them go back to detention and start all over, can we intervene? Can we do some direct transfer? And then looking at what are the factors that are contributing. So I like to think of our continuum as kind of like a stoplight, green, amber, red. Green, you're out, you're free to move about, you're in an evidence-based intervention such as FFT, you're living in home, you're receiving targeted case management, maybe outpatient services. The amber is you're putting your head down on a pillow that DJS is paying for, however, you're still going out in the community to school. And then the red is the secure, staff secure and hardware secure. And we do have to look at our continuum through the lens of restrictiveness, because we are public safety and we have to be focused on community safety. And then also within that, what are the treatment needs? And there's a slide that's coming up that doesn't, I think, look the way, yeah, oh, it did, okay, good. This is the slide that shows where our secure programs are as far as restrictiveness, community-based residential that we have, and community-based in-home. So this pie kind of reflects the contracts that we have. Obviously doesn't reflect all of the programs that we use that we don't pay for, that are linkages in the community. All right, so the evidence-based and promising programs that we use for youth who are formally involved with us, under court order, and at risk of placement, because once you're on probation, you are at risk of placement. Functional family therapy, multisystemic therapy, family-centered treatment, which is a trauma treatment model and is approaching, I think, becoming evidence-based. The Youth Advocate Program, which is a research-based program, and then UMBC Choice, which is just an excellent program, 30 years of working out of the University of Maryland, Baltimore County, we had Freeman Rabowski. Dr. Rabowski was a speaker yesterday. He talked about how there were some attitudes about having our kids on the campus of UMBC years and years ago when they transferred it from Cherry Hill to, and that campus has welcomed our children and really worked with them. And these are children who've done some things and really worked very effectively with our kids. So very proud of that partnership. Where are the functional family therapy programs in Maryland? Metro, Central, Eastern Shore, and these are the providers, Vision Quest and Center for Children. Where are the multisystemic therapy programs, MST? Montgomery and Prince George's, Baltimore County, and Frederick and Washington. And I would like to just mention that when we rolled out these evidence-based blueprint models, they were in a lot of different areas of the state. And what happened was some right sizing occurred and some matching with the community, because you do have to look at cultural competence and matching what a community needs. So there are always questions about why here, why there. And that can shift over time based on what the community needs are. So when we get into residential, here's the kind of the amber to red. Our residential program levels must be defined by law. Department of Juvenile Services must define our levels of care. So, and again, it's through restrictiveness, and then within that restrictiveness, what are the treatment needs that these programs can meet. So our level 1 community base, we do still use foster care, treatment foster care, group home, high-intensity group home, alternative living unit when available to us through contract, and independent living. And most of these programs, and many of the level 2 programs, are not licensed by DJS. They're licensed by our sister agency, Department of Human Services. And, you know, we have the crossover initiative for a reason. Many of our kids have similar needs. Many of the kids are involved, the children and adolescents, are involved with both departments. And so many of these programs can meet the similar needs of the population. A question I get is, level 2, staff secure, we have group home and therapeutic group home listed, just as we have it listed in our community residential. And the reason is that there are some group homes and therapeutic group homes that actually have on-ground school. So when you think about how I define staff secure, 24/7 eyes on supervision, all the programming is there, you don't leave. So we have some programs that do meet that level 2 staff secure definition because of their configuration. And then the level 3 is the hardware secure. And of note, in both levels, there are RT seats. So this is kind of an illustration of the fact that we look at restriction. What is the level of restrictiveness needed? But then within that, if we have kids children and adolescents who have very high mental health need and they meet the medical necessity criteria for RTC, then we can place them there. What are the current needs of our population? When you look at, we talked about how, or I talked to you about how our placement numbers have gone down, our probation numbers have gone down. So you can imagine that the intensity of the need of those youth that remain because they were not able to be diverted. And we still have room to move, by the way, on that part of diverting kids. But the needs, the critical needs of our placement population tend to be the kids that have trauma, they have incarcerated parents, they've experienced homelessness, they're crossover youth, they have mental health, substance abuse, physical aggression, developmental issues, and educational needs. And this is an area where we're really starting to have a better, more deliberate working relationship with Department of Disabilities, DDA, because we need the expertise within our own facilities. We have a lot of kids within our facilities that have public safety issues and need to be in a restrictive setting, at least initially, and they also have DD issues. And we need to build expertise within our staff, get some technical assistance so that we can meet the needs of those youth who frequently are the kids who are ejected because of our programming being lacking. When we remove kids, we have reentry. And reentry aftercare is what you'll hear about. Also, reentry can be equated with permanency planning. So when we are discussing and planning removal of youth, we talk about permanency at that time. We are part of the statewide 4E and 4B plan, and we have requirements. We have 4B administrative reviewers to make sure that we're looking at permanency for kids. So our reentry process, and by the way, we have a reentry strategic plan that's on our website that kind of outlines this and outlines what we're measuring, but it really involves engaging families from the very beginning. And we do flag youth who look like they're going to need housing initially, right up front, because we do have some youth who are aging out and do need independence and need our help in transitioning them. Connection to local education resources, career development, paying restitution, and looking at their behavioral and somatic needs. A lot of the youth who come to us and end up in our residential programs have a lot of health needs that maybe have been unmet. We spend a lot of time making up for dental services that they need, getting them glasses, a lot of somatic issues. And then we want to make sure that when they're going back, that if they have ongoing needs, they have connection. And these are our goals. I'm not going to read them to you, but they're pretty logical. I don't think you would disagree with any of these. Recidivism is our big measure. Well, what mitigates against recidivism? If you have connections, social connections. If you can figure out something you're good at, that you're going to be able to make a living at, that there are career paths for you, and that if you're having mental health issues, addiction issues, that you have support. And one of the big things that we're really looking at is how do we move our staff into, not just in the residential, but in the community, cognitive behavioral programming with role modeling and teaching you, change your thinking. Here's why the thinking isn't working. Let me show you a more effective thinking and operating in this world. Because we do have youth who have antisocial thinking, and it's been reinforced. And we're needing to really look at, not lecture, not yell at, that doesn't really, and also we're really looking at, let's make sure that we're reaching the high risk and giving them, a wonderful speaker this morning, I'm benefiting from that, but giving them the proper dosage of what they need and making sure we're not giving doses of this to the lower risk kids who not only don't need it, but we may hurt them if we do. So some initiatives, behavioral health diversion initiative. This has been very recent, and we're kind of researching it as we go, looking at, okay, you saw how powerful intake can be in diverting. Are there youth and families that we can really flag who have specific behavioral health needs and not just divert them and hope that they make a connection, but actually do some further assessment and a stronger, really warm handoff linkage and some monitoring to make sure they get to where they need. Crossover Youth Initiative, very powerful, very good outcomes. We've been piloting this and expanding it now with our sister agency across the state. And it really is about, and the local care teams will love this, it's about DJS and the local DSS playing nice and talking in language that we can understand with our other partner agencies and looking at joint planning, looking at when kids hit our systems, how can we work together so that we're not inadvertently preventing them from receiving service or disrupting. Very powerful, and it's through Georgetown Institute. So the pilots in Maryland and then the small local jurisdictions where it's been implemented have informed Georgetown Institute's project and helped develop some real specific protocols that work. Family engagement, peer support specialists. Juvenile services has always benefited from the family peer support, family navigators that were developed through wraparound and other initiatives in the mental health field. But really for the last year and a half, we've had our own contract now. It's the first time we actually said, hey, let's make it specifically for DJS kids. And so it's really helping. It's helping, I can give you anecdotal examples, but, youth and family where the youth has significant addiction issues and having someone who's kind of a support with the family. And so the last thing I want to say before I really make an advertisement again for Data Resource Guide is just a brief legislative update that this legislative session, there was a law that was passed that it's a child abuse law, that it's a crime for a mandatory reporter to fail to report child abuse. Yeah, it's not just, oh, you're required to because you're mandatory. It's a crime if you have direct knowledge and you fail to. Fatality reviews are going to occur for juvenile services youth who either are the victim of a homicide or caused the death, commit homicide. And that is going to be an expanded state advisory board process to really take a look at, what happened here and what are recommendations out of this. So that's a really great thing. Also, the legislature passed a bill, and it was signed into law, that there's a juvenile justice council. It's going to be short term. It's going to be 2 years. That's going to, the charge is bring expanded partnerships together, develop a framework for how you're going to reform juvenile justice, research and look at best practices, and then really develop a system where there's a lot of focus on prevention. So we're really excited about that. And it really dovetails with the reauthorization of the federal Juvenile Justice Delinquency Prevention Act. That act really supports a lot of the things that we've been trying to do in Maryland. And the thing that really is added that is going to be an interesting impact is jail removal. So that we've been working hard to have kids who are charged as adults but could be transferred to juvenile, to have them held in detention rather than jail pending their transfer hearing, to have them transferred to juvenile court. This says, hey, you got 3 years. You're going to have to hold them in juvenile settings until their trial. Even if they're not, even if they're kept in the adult system, you still hold them. Because what happens is at trial, sometimes if there's overcharging, a youth could actually be found to have committed a lesser offense. And if they had been charged properly, I'm saying in a very judgmental way, but if they had been charged initially with that lower offense, they wouldn't have even been considered an adult. So this idea is, come on, hold them. So it's going to impact our detention length of stay. It's going to have, but it's something that we support, and we're going to work on it. So like us on Facebook. We have some fun stuff on Facebook. Look at our data resource guide. You just got to love a delinquent. And thank you very much.
Thank you, Pat. We are going to pass it over to DDA. And just as a friendly reminder, folks, if you have any questions, go ahead and throw them into the chat pane. It doesn't open by default, so you do have to open that. And also, if you have any technical assistance or technology problems, we can coordinate those to the chat. Thank you.
Okay, I'm going to start off with, my name is Janet Furman. I work for the Developmental Disabilities Administration as the Director of Children's Services, and DDA does serve children. I know you all have heard differently from time to time, but we do serve children, and in fact, we currently have about 152 kids in our waiver services right now, from the age of 3 through 20. So, DDA believes that all people, including those people with developmental disabilities, have the right to live, love, work, learn, play, and pursue life aspirations in the community. That's really important because essentially we want people who are in our system to be able to do the same things that we can do. You can read a lot of the rest of this, but what I wanted to focus you on is that we are also one of many resources, services, and supports that are available. We are not the only resource available to people with disabilities. And we really want to work together with our partners to help people build lives toward their vision of what a good life is. And talk a little bit about eligibility versus entitlement. In Maryland, in the school system, kids are entitled to special education services or education services until they reach the age of 21 years old or they've met the requirements for a high school diploma or certificate of completion. Once they leave the school system, they don't have an entitlement anymore. They have to meet the eligibility criteria and the funding availability, either to get into post-secondary education services or to receive services from adult children's agencies. And DDA services are provided based upon eligibility and availability of funding. So one of the things I want you to know, and it doesn't exactly fit here, but DDA offers low-intensity support services. It's a really cool program. It allows an individual or family to receive up to $2,000 a year of some support services that would assist in supporting the individual or family. Services can be assistive technology. We've done a lot of iPads and iPhones. respite, childcare, specialized equipment, specialized strollers. We have provided some fencing. I do believe we did a little bit of a bathroom modification for someone. We've done ramps. So there's a lot of really cool things we can fund. The caveat in this is that you do not have to be DD eligible. You do have to have an intellectual developmental disability, and it's random selection. So we have 2 rounds. One is going on right now through the end of June, and then people will be selected in July, and they will be able to access that $2,000 for an approved service. The second round starts at the beginning of July and goes through October, and they are usually approved in November to receive the second pot of money.
Can you give an example of assistive technology?
Assistive technology there's a wide range of assistive technology. It can be something like an iPad. It can be a communication device. It can be something as simplified as, I don't know exactly what, like a lotion applicator, or a sock putter on her.
I'm thinking, would this be something that would be helpful for, say, a youth whose guardian might need the assistive technology? Would that be an option for them to communicate at perhaps like an LCT meeting?
It could be. Okay. It could be. I mean, we like to focus the services on the child, but if the child's guardian needs the support to communicate with them, then that's a possibility. And then we have, I don't know why I just said Maryland Community Connections. We actually have 2 providers, and I missed this. Maryland Community Connections handles the southern and eastern shore regions, and Penmar Human Services handles the central region and the western region. Our regions are not the same as DJS. They're close, but our western region hits Allegheny and Garrett and comes back through Carroll County. Our central region is Baltimore City, Baltimore County, Harford, Howard, and Anne Arundel County. And our southern region is Montgomery, PG, Charles, Calvert, and St. Mary's. And then everybody else is the Eastern Shore. And there's more information on our website about how to access the list services. The DDA application process, it's long. It's gotten better. So the first step is to contact DDA, or you can go right on our website and submit an application to DDA. Once that application is received at one of our regional offices, they assign a coordinator of community services. The CCS is a case manager, a coordinator of those community services, and they're contracted with us. They perform a face-to-face assessment. They ask for documentation, which would be functional assessments, psychological evaluations, an IEP, possibly anything that would show that the person does indeed have an intellectual developmental disability and has functional limitations. The CCS will then provide us with their recommendations and support, and our regional office will review the packet. And in some circumstances, we ask a consultant to look into things if there's applications that we have some concerns about. And then the regional office will make a final determination and notify the applicant. The final determination could be that they needed more information. It could be that the person is not eligible. It could be that the person is eligible. But anyone who applies will receive that letter, and it will include the right to request a reconsideration, the right to a case resolution conference, and or the right to a Medicaid fair hearing. And everyone is entitled to request that if you're not happy with the determination. The DDA will accept applications at any age and at any point in a person's lifespan. And then even if you're eligible, it doesn't mean that you're going to get funding. We have limited funding, and we have to prioritize people based on their needs. And so each person who is found eligible is designated to a priority category. And when funding is available for that priority category, and the person has a need, the coordinator of community services is informed, and they will help the family or the person explore services and provider options. These are our regional offices. It shows the county served. It shows the addresses where they're located and phone numbers for their services. Here's where our application is located. It is on the DDA website, and it is fairly easy to get to from this link. So DDA has 3 home and community-based waivers currently. Our deputy secretary came in with a vision of really supporting families and was able to have 2 new waivers created. One is the family supports waiver, which is dedicated just to children birth through age 21. It offers various support services, and there is a service cap of $12,000. The community supports waiver is very similar, but it's open to children and adults. And in addition to the support services, it includes meaningful day services. And there's a service cap of $25,000 a year. Our community pathways waiver is our comprehensive waiver, and that's for both children and adults. And it includes, again, the same support services, meaningful day, and residential services. In all of these waivers, people have the option to self-direct their services if they want to, or to use the traditional service delivery model. So what are our services? Our services include assistive technology, behavior support services, which includes assessment, a behavioral consultation, development of a behavior plan, and brief support implementation, which is somebody coming into the home to help implement the behavior plan. It includes camp, environmental assessments and modifications, family and peer mentoring services, family caregiver training and empowerment, participant education training and advocacy, personal supports, which are habilitative services provided in the person's home or in the community to help the person gain skills to better access their home and community, remote support services, respite care, transition services for kids that are transitioning from the education system into adult services, transportation, and vehicle modification. There are some limitations on some of these services, and if you need more details, they're on our website, or we can get them for you. The DDA representative at any of the LCT teams should be able to share this information with you as well. So specific to children's services within the children's service system, DDA has 14 licensed residential ALU and group home programs. They are licensed by DDA, and they are contracted by the Department of Human Services and the Department of Education through the autism waiver, and some of the local school systems. They are monitored by any of the departments that contract DDA and the Office of Healthcare Quality. So there's a lot of people going out to all of these programs. These programs include services for kids who are medically fragile, as well as services for kids who have intellectual developmental disabilities, and a lot of them have autism, some comorbidity, and sometimes very challenging behaviors. And that's DDA.
Thank you, Janet. We are going to pass this over to the Department of Disabilities, Elizabeth Hall.
Hi guys. My name is Elizabeth Hall, and I'm the Director of Interagency Affairs at the Department of Disabilities. Before I begin, the Department of Disabilities is a little bit of a unicorn, as in we are the only state that has a Department of Disabilities at the executive level of our state government. We existed in some shape or form since the 70s, and in 2004 we were bumped up from a governor's coordinating office to a Department of Disabilities. That was because it was for a couple of reasons, but one of the reasons was that there was from the federal side, there was a want to have more oversight, making sure that people with disabilities were being put in settings in the most integrated setting possible. And the states were being highly encouraged to track that. And so since we already had an infrastructure in the governor's coordinating office, they bumped us up to a department. So we've been in the department since 2004, but we've been in existence since the 70s. So our mission, the easiest way to describe it is we are the disability policy part of the executive branch. And our mission is changing Maryland for the better by promoting equality of opportunity, access, and choice for Marylanders with disabilities. Okay, so we do this by promoting full community living for those with disabilities in Maryland. We coordinate disability policy across the state and changing Maryland for the better. Maryland Department of Disabilities collaborates with state, federal, and private partners to ensure delivery of services in the most integrated settings possible, develop consistent policies affecting those with disabilities, and we really try to consider the diverse needs of all when making decisions which impact Marylanders, guaranteeing opportunity and access and choice for those disabilities at every level of governance, and develop and coordinate the state disabilities plan. The state disabilities plan, which I am in charge of, it coordinates services and policies to ensure compliance with civil rights laws and promotes and provide community-based supports, emergency preparedness, housing, transportation, employment, healthcare, accessible technology, education, and family supports to Marylanders with disabilities. Every word that is in italics at our office, we have a policy specialist. So we have a policy specialist in community living, emergency preparedness, housing, transportation, et cetera. The state disabilities plan provides a framework for delivering, monitoring, and striving for improvement in these services. So it's based on these 4 goals, and these 4 goals were developed from the Hogan pillar, and so that began in 2000 when he began his term in 2015, and he has not changed it. So it's probably this year when we're going to be redoing the state disabilities plan, they're most likely going to look very similar. The one that I wanted to highlight was the maximizing resources. This group is actually a great example of the maximizing resources goal, which is Maryland state agencies will continue to identify ways to improve the efficiency of service delivery and, where appropriate, find ways to expand or develop programs. And so this is really focused on maximizing resources in health and behavioral health care and family supports, but also tracks efforts to improve and expand resource capacity. And so the IPC's work during the past 2 years that I've been here, is a really great example of that. So our services and programs, we have, so Access Maryland is a program that gives out funds to make state buildings more accessible. The attendant care program would be for somebody with a physical disability that needs an attendant care person to help them complete activities of daily living. We have a community living policy coordinator. We have a constituent services director who you can call, and she's wonderful, about any number of constituent concerns. Employment policy coordination, housing policy coordination, which has services and programs for people with disabilities. The Maryland Promise, which was a a 5-year research project that's kind of winding down on youth with social supplemental security insurance. The Maryland Technology Assistance Program, and also Transitioning Youth. I just wanted to highlight a few of them. So the Community Living Policy Coordination, we have a person that works in programs that coordinate state agencies to ensure policies and services support integrated community-based services, and also worked with our partners at DDA to ensure that individuals receiving long-term services and supports through home and community-based service programs have full access to community living. The constituent services that I was referring to, that provides information and referral, resource listings, access assistance to individuals with disabilities and their families and caregivers on issues, including employment, housing, transportation, emergency preparedness, and benefits. Our Director of Constituent Services, I put her name and number on the slide. Nan Birdigham is a gem. She has worked. Last year, she got her 40-year pin, so she started when she was 5, and she is just a wealth of information, and she's wonderful, and so please call her. The Housing Policy Coordination, we have two programs under this branch, and so that the goals are to increase housing for people with disabilities, in affordable housing, and promoting more choice and opportunities for affordable and accessible housing that is near, transit and services, so you don't need a car. So if you are interested in finding out more, Chelsea Heyman, who is our Director of Housing Policy, that is her contact information. Kind of piggybacking off of what Janet was discussing about the Maryland Technology Assistance. So the Maryland Technology Assistance Program, it's a federal program so every state has one, and in Maryland, it's under us, and it's a federally funded program that has a lot of great resources, which includes an assistive technology loan program. So if you are thinking, yes, I need some kind of assistive technology, but you don't really know what, they have this great assistive technology library at their main office, and you can try things out. And there's also a loan program, because some of the assistive technology can be a little expensive, but they're just awesome and great, and they're very, very knowledgeable about what they do. So highly recommend them. We also we're involved with transition services in a lot of ways. We are a member, and actually I staff the Governor's Interagency Transition Council for Youth with Disabilities, and so that group, we also have a transition youth website, and also you can also find support and resources through our constituent services. And so that's my information. If you have any other questions, please contact me.
Thank you, Elizabeth. Next, we're going to hear from Caroline Jones at the Behavioral Health Administration.
Move the computer down her way.
Good afternoon, everyone. My name is Caroline Jones, and I'm the Chief of Child and Adolescent Services at the Behavioral Health Administration. The Behavioral Health Administration is a department that is under the Maryland Department of Health, along with Janus agency CDA. So we have the same secretary that oversees our services. The Behavioral Health Administration is responsible for the oversight of public mental health services, which means that we serve youth and adults who have medical assistance as their primary insurance. And so we are responsible for making sure that those youth and adults get services that they may need in the community to continue to be healthy. Our mission statement is here. So it is really important for us to make sure that we promote recovery and resiliency through plans and everything that we work on with youth that are engaged in our services. Won't go into detail, but we also want to make sure that our system is resilient, promote recovery. We are very integrated, so we work a lot with sister agencies, making sure that those youth that Pat talked about get access to behavioral services. And sorry, what I didn't really say is that the Behavioral Health Administration back in 2015, I think now, merged with the ADAA to become the Behavioral Health Administration. So we have sight for over substance use services as well as mental health services. So a lot of our services are oversight provided by or oversight by the core service agencies or a local behavioral health authority. So those authorities are local to each jurisdiction. It may be a core service, it may be a local behavioral health authority. Some of them have combined, and that is why they are now a local behavioral health authority. So in their communities as well, they've combined their mental health services with their substance use services. So today, just really quickly, I'm just going to go over that person's role on the LCT. Because the Behavioral Health Administration does not have a person that sits on the LCT, so we coordinate very closely with the LCT members, which is a person that comes from the CSA or the LDHA. The local addictions authorities also in some jurisdictions will have a member that sits on the LCT as well. So what is a local behavioral health authority? So I told you a little bit about the Maryland Department of Health, and we fall under the Maryland Department of Health. So the local behavioral health authority and the core service agency and the local addictions authority, like I said, are those local agencies that oversee those services in their community. And they will be the individual that sits at the table for coordinating purposes at an LCT. But if you have a youth that would require additional consultation and stuff, those people are who actually I look to and communicate with quite a bit on cases of children that have these services or are in need of services. So here it goes into a definition of the local behavioral health authority, or gives you more information about their funding. So what are their roles and responsibility on the LCT is to ensure that the youth or family gets access to behavioral health services. They advocate for policies to advance prevention and early intervention, treatment and recovery. Once again, collaborate with system partners to improve access to care, especially our sister agencies, like I had mentioned before, and to make sure that at a local level, communities are strengthened by supporting behavior, health, and wellness and recovery. This just goes into a little bit more specific of their roles, and so they do a lot of care coordination, service types, and looking at to make sure that the individuals that come have received services in the past. So if you have a youth that may be eligible, the core service or the LBHA is really good at looking at services that they may be eligible for and reaching out and assisting you with reaching out, getting to Beacon Health Options, who is our ASO, and they are the ones that will approve the services.
What is an ASO?
An ASO is an administrative service organization, sorry about that, and they are contracted with the Maryland Department of Health through Medicaid to oversee the public behavioral health service.
Thank you.
Yeah. So how we fund it, how those services funded. Most services are two different types of funding. They can be a fee-for-service, which is through your ASO, or grant funds. Each core service agency operates very differently. So some agencies may have some additional funding where they can assist and get you services for youth in the home on a very limited time basis. Some do not. So each jurisdiction is very different in how it operates. Oh my goodness, I can't even see that. So sorry, you guys, and this helping. So the core service agency is responsible for reviewing eligibility based on criteria. So as I talked earlier, they will look at youth, see what they may be eligible for, review medical necessity, and then refer youth for services through Beacon Health Options. Here's a list of our public mental health services that are available for children. Targeted case management is in each jurisdiction. Some of them are not in all jurisdictions, unfortunately, but we do try to keep track of, we're always recruiting providers into the communities, and that recruitment is usually done through your core service agency. Targeted case management is in each jurisdiction. We really like to make sure that all the youth that are eligible will receive those services. Targeted case management is 3 levels of service. So based on the intensity of your need, there's an assessment that's done through the core service agency and Beacon Health that will determine the level of services that you need. If you get to level 3, there's an additional service that the youth may be eligible for called 1915I waiver services. So that's a grant funded, those are public mental health funded services as well, and based on eligibility and financial eligibility. So not all youth are eligible for those services. It is based on income. Psych rehabilitation programs are in every jurisdiction as well, and those are services that can reach out to each youth to help them to become, people say it's mentoring, but it should not be mentoring in each community, and I hope people really understand that we don't pay for mentoring services. These are goals and objectives, and they are treatment plans that should be established to help a youth. And the only other one I would really point out, and unfortunately we don't have in every community either, is therapeutic behavioral services. However, very short term, usually once again, authorized through Beacon Health Options, but these are services that are targeted to really focus on a child's maladaptive behavior. So like if you have aggression and you want a child to really focus on that, they will come out and work with each youth just on that. It is a evidence-based service. And we do find it to be extremely helpful for youth in the community. We just unfortunately don't have providers in each jurisdiction, but providers can cross over jurisdictions to provide service. And if the most intensive that we provide, well, that we oversee, we don't provide any of these services. It's really oversight, would be youth that would be placed into a residential treatment center. And those youth should come before your LCT to receive any of those services or to be placed. You have a slide here that gives you access to the link for the Maryland Association of the Behavioral Health Authorities, MABA. And MABA also has the local addiction authorities as well. And that is it. And then you have my name and email address. So if anyone has any additional questions, please feel free to contact me.
Thank you, Carolyn. We're going to hand it over to our friends at Department of Education.
Thank you, Lauren.
Yeah, thank you.
Good afternoon, everyone. My name is Sheila Phillip, and I am the section chief for non-public special education at the Maryland State Department of Education. And we collaborate and work very closely with all 24 local school systems, our LSSs, as we refer to them often. So I wanted to make sure I noted that because I slip into the using those letters, yeah. And we also, you'll hear us referred to quite often as the MSDE. So I just wanted to briefly provide a little bit of an overview of the local school system process. So the work with our students with disabilities really is driven by the IEP, the Individual Education Program team. And so at the local school system level, they may identify a child that has needs. And so they may reach out to our section at the State Department of Education. And we actually sit within the Division of Early Intervention and Special Education Services within the Resource and Management Monitoring Branch. And so our local school system partners might reach out to us asking for some kind of guidance or kind of help them kind of think through some of the identified needs that they're having for ideas on thoughts on maybe placements or resources that might be available. And then we always make sure, and quite often, hopefully, they are referring to the local care team. And we always make sure that we ask as part of that discussion with them, have they reached out to the local care team? And so, excuse me, because we want to make sure that our local school systems are really partnering across agencies at that level to also explore if there are additional resources and supports that might be available within the local community that would be supportive to our students and our families. So then they might take that information, they'll probably be taking that information back to the Individual Education Program team, discussing the needs, options, placement options, if that's kind of where the IEP team is going. And if appropriate, they might approve a placement. And the MSDE is also involved in tuition assistance for the non-public placements of our students. And so they would submit an approved cost sheet from the schools where the student is referred, and also an approved non-public tuition assistance application to my section. And generally, we strive to have those all submitted within 30 days of the student's date of enrollment in the non-public placement. And the local school system is responsible for monitoring that student's progress And we'll convene IEP teams as needed, and those occur at least annually and at the minimum. I also like to point out, so the local schools, the non-public schools and non-public special education schools here in Maryland are approved by the Maryland State Department of Education, but there is a separate branch, separate division outside of the Division of Early Intervention and Special Education Services, and that is Educator Certification and Program Approval. And there is a branch led by Alex Canberra called the Non-Public School Approval Branch, who is actually responsible for the approval and monitoring of non-public schools. So I wanted to talk a little bit about how we collaborate with our local school system partners in out-of-state placement. So again, the LSS, they're going to be identifying needs at the IEP team level, and they're going to reach out again and consult with us when they're considering an out-of-state residential school placement. There's a couple of reasons that they're going to do that. One is to explore that alignment of the out-of-state school program with Maryland standards and COMAR for non-public schools. And that actually is a process that is completed by my section. And it's also important to note, like for in-state non-public special education schools, the MSD actually does certify and approve those programs. But for out-of-state programs, we rely on the out-of-state departments of education to approve those programs, or we will reach out and determine if that is done at the state level of our sister states. But it's important to note that at that time, with the work that we do, we're not approving, and I kind of put that in quotes, the educational program or the residential program of that out-of-state school. We're really looking at it as kind of a blessing for state tuition assistance, which I think is a very important distinction for us. And as part of that work, we're really taking what the COMAR, the Code of Maryland Regulation standards are in Maryland for a non-public special education school. And we're looking at that out-of-state educational program to determine if they substantially meet the Maryland COMAR requirements. And so we have a process that we do to kind of get that work done, which includes reaching out to that program, having them send us information. We have a discussion with their education director. And we're also asking our local school system partner to make sure that they are kind of looking at that program too, to explore and make sure that that program is appropriate for the needs of the student that they are looking to refer there. We'll also have a conversation with the Department of Education that licenses or approves that out-of-state educational program. And we are also going to have discussions here at the Interagency Placement Committee level to kind of get any input or feedback from our sister agencies about any experiences that they have, whether they have current contracts with those programs or have done any site visits, things like that. We also require our local school system partners to complete a site visit before they place a student at a new program that they don't currently have students at. Again, that is to verify the program, the educational program, and the residential component of that as well. And we might also call and discuss the residential component of a program out of state with that state kind of Department of Human Services that's responsible for licensing their out-of-state residential programs. We're also going to look to whether that might lead to the availability of state tuition assistance for that program. And we will also confirm with our local school system partners all of the requirements related to all of that work. And again, once the student is placed at a non-public school out of the state of Maryland, we require they submit a site visit report to us at least annually. And that should be done within 30 days of their site visit. And in these cases too, right, so when there's a potential placement of an out-of-state placement for a student, we would also be encouraging our local school system partners to reach out and refer to the local care teams to make sure that all the local options have been explored and Also that given the parents and the families an opportunity to get to know the other agencies and the supports and resources that are available in that local community. Because the goal at some point is that that student is going to return to their local community and they may be in need of those resources and supports. And perhaps even some of those things that the family can engage in can help the student return sooner. So it's an ongoing process, and hopefully everybody's working together to facilitate that work. When we think of the local school system as an active member of the local care team, the expectation from the State Department of Education and our section is that they're going to be referring students and families for a support and guidance from the local care team and the local school and the local partners at that table. And that they're going to be an active role, take an active role in that process as a local care team member, collaborating and through the process to make sure that the team can develop and implement a full plan of care that meets the needs of the student and family. And also identify those appropriate supportive services that can best meet their needs as well. And so please know that that our section values the role of the local care team in the work. And just so you also know too, I used to work for 2 local management boards long time ago in Calvert and St. Mary's counties both. And so this process really has a near and dear place to my heart. And I think that kind of covers what I wanted to provide an overview of, and you have my contact information there as well.
Thank you, Sheila. And last but most certainly not least, we will hear from our friends at PHS. You need to be prepared. You're so good.
So good afternoon, everyone. I know it's kind of late. We've been sitting for about an hour and a half, so I'm going to try to be brief. You have a number of slides, probably about 20-something slides. I am not going to review 20-something slides. It's not going to work. So I am Tennille Thomas. I am the Chief of Staff for the Social Services Administration within the Department of Human Services. As we all know, the Department of Human Services is the Human Service Child Welfare Agency within the state, and SSA, which is a branch underneath, is responsible for helping families stay stable, safe, and healthy, and for protecting children, youth, and vulnerable adults. I'm not on the slide yet, so don't worry about it. Protecting children, youth, and vulnerable adults from abuse and neglect. And we always think about DHS and SSA with serving children and families. We never really mention that adult protective services is an entity under the purview of SSA. So while today's kind of focus is on child serving youth, I do want to recognize that we serve youth 18 to 21, and they are considered adults if they do not have a neglect case. And so we are responsible for ensuring that they are safe and they have the services that they need. So I'll pause right there and move forward. As you can see, the leadership of SSA, our executive director is Rebecca Jones-Gaston. Brandy Stockstill is our deputy executive director of programs. David Ayer is over operations, and myself. Our vision, again, is to help families stay safe, stable, and healthy, so that our children and youth and vulnerable adults are protected from abuse and neglect. SSA is unique as we are not a direct care agency. We are responsible for implementing the policies and practices that the local departments utilize to ensure that youth and adults are protected from abuse and neglect. And as I indicated with DHS, we've kind of reformed for our residential care purposes the regions that we utilize, but we all have local departments in each of the 23 counties and Baltimore City. Child welfare, I'm going to start with, has taken and I'm going to skip to the next slide. As you can see, over the past 12 years or so, and looking at this slide, you'll see child welfare and our initiatives have changed over some time. In 2007, we started with family-centered practice model and place matters, which was an effort to serve children and families in their homes and communities. Alternative response was a piggyback on that, where instead of doing CPS cases where children were removed from the home, there was an effort to serve those children within their home. Then those three efforts led to Families Blossoms. And Families Blossoms was a big initiative where the federal government allowed us to take advantage of a lot of money to provide evidence-based practice services, which again focused on serving children and families in their homes and communities, and giving us the opportunity to think outside of the box on how we could serve those children and families in their communities, while also giving us an opportunity, as you can see, to embark with everyone around the table on our Children's Quality Services Reform Initiative, which, as everyone across the state knows as RACE Reform. We've also been able to, or will be going into, an initiative of getting a statewide hotline. Our system, modernized SACWA system, which we are working with DJS, which is called CJAMS, where we'll be connected. We currently have a system called MD Chessie, and now CJAMS will kind of take over, where we'll be able to interact and see the cases that we share, and have more communication and be better able to plan for youth. Then we have, which everybody loves now, the new federal legislation, which is Families First Prevention Services Act, which passed in February of 2018, which really focuses on serving youth in their homes and communities. And that is what we've been doing for the past 12 years. So Maryland is on kind of the front end of the initiative. And then going forward, our waiver will end in September 2019. But with the waiver, we've been able to introduce our integrated practice model, which will again allow us to continue to serve families and children in their homes. But I'm going to skip the priorities because we've all gone through that. And it's really, again, promoting safe, reliable, and effective practices so that we can work with youth and families. I'll skip those. And the Families Blossoms Place Matters at the house. And this is a part of our integrated practice model, and it builds on the foundation of serving children and families. And oh, no. I'm not good at the clicker. All right, so the Maryland's integrated practice model, again, and it's kind of a blurry slide. I can't see it. So the practice model really looks at providing individualized services to children and families. Again, the focus is serving children and families in their homes and communities. The key, which connects to the house, the key connects to the house. It's like you're opening the door. And so we want to be able to recognize, I didn't get that, it was a plug. The practices and principles that we're utilizing in our priorities, if you float back to the slides, around this key. We want to be trauma-focused, strength-based. And so all of these will help us in serving our children and families with that focus of making sure that the services that we're providing are individualized. Okay, next. So SSA is comprised of in-home services and out-of-home services. In-home services consist of our CPS side and family preservation. So again, we're starting with hotline and intake. We're looking at risk of harm, investigative responses, alternative response, and safety and risk assessment. In addition, we are looking at human sex trafficking, child fatality, birth match, and completing those CPS background checks, which we need for all of our staff at the residential group homes, our CPA providers, school systems around the state. So those services are offered within our CPS and in-home services. Placement and permanency is a part of our out-of-home services, where we're looking at foster care to include kinship services, adoptive services, resource homes, and independent living, and everybody's favorite, placement services. And then we look at types of placements, where we place children, residential treatment centers, treatment foster care via private agencies. We have 33 contracted providers across the state. We have group homes to include high intensity, therapeutic, traditional, diagnostic, medically fragile, and DDA contracted providers. Youth are able to do trial home visits, regular public foster care, and all intents and purposes, kinship care. And we've been able, in this past legislative session, to have legislation passed so that we now have fictive kin, where a child can be placed with a non-relative who they have a relationship with. And then we have emerging adults. These are our older youth that we are looking to transition into successful adults. If somebody can define successful adult for me, that would be wonderful. But that means having children be able to transition out of care and be able to thrive. So we're using independent living. We have credit reporting services, Ready by 21, employment opportunities, tuition waiver, which is a big help for our youth in paying for education post-high school. And if I'm not mistaken, they increase the age that youth can access the tuition waiver up until the age of 25. The youth have the opportunity to provide feedback on the services and trends that affect them as youth and how we are able to carry out child welfare practices through the State Youth Advisory Council. And Thrive at 25 is an initiative that is based on the Eastern Shore that focuses really on those youth transitioning out of care. And then one thing that's not on here is the Foster Youth Savings Plan, and that is a financial literacy opportunity where youth are given a stipend. Youth 14 to 17 receive $350 a year, and youth 18 to 21 receive $800. And with the financial literacy, it's a savings account for youth to use when they transition out of care. With that, there are incentives. There's a $500 incentive if you graduate from high school. There's also a $500 incentive for those youth that complete higher education, job training, or certificate programs, and that includes those youth who are obtaining GEDs.
Are they automatically enrolled in that? Or
yes.
Okay, thank you.
Everyone is enrolled at the age of 14. Then looking at recruitment and retention. Of course, we want to look at recruiting and retaining foster parents for our youth, where that's where we want to place youth, not necessarily in congregate settings, but if at all possible in family settings, and hoping to get them to permanency with adoptive families, and with that offering post-adoption supportive services. And you see those services, which are adoption subsidies, those you still have access to the tuition waivers, search, contact, and reunion services, and confidential intermediaries. And of course, Office of Adult Services is not one that we normally talk about in this forum, but we do offer services to our vulnerable adults across the state through APS, adult public guardianship, social services. We have in-home aid services, project home, and respite care programs. And our last area is our Office of Outcomes Improvement. In this area, we are looking at ensuring that our workforce has adequate training, that we are able to do quality assurance assessments of the local departments and the care that they are providing to the youth entrusted to them, and practice interventions where we're looking at the practices that we're carrying out to make sure that they are the most appropriate in serving our constituents. And of course, again, I'm Tennille Thomas, Chief of Staff, and there are the links if you need more information.
Thank you, Tennille. So that wraps up our presentation part of today's webinar. So we're going to open it up to questions. If you could just utilize the chat function so we can cut down on how many voices we have going at the same time, that would be great. And we will just repeat your question for everybody to hear. So we'll just give you a couple minutes to get your thoughts together and get those questions in. Okay, so we're going to go ahead and just start reading some of the questions that have been entered. Looks like somebody asked, what was the name of the program to help adolescents finish school by giving stipends and incentives?
Tuition waiver.
Yeah, so we did cover that. That's the tuition waiver. Thank you, Tennille. Will a recording of this presentation be made available? Yes, it will. It takes about a day for those recordings to generate a link, but we will let you know when they've been posted. And yes, we will also make the slides available separately if you want to just review the slides on your own time instead of through the webinar. It would be helpful to have descriptions of each of the programs offered by the agencies who presented today. I know that some of the programs that were described, those descriptions do exist in some of the resources they linked into their pages. So if you go, when you get the copy of the slides, if there is a specific program description that you're missing, feel free to reach out to that specific person or reach out to me. But I think most of the programs discussed were linked through either like the resource guide or websites or catalogs. Okay, and we will leave it open for more questions.
Yeah,
there were
earlier ones.
There were earlier questions.
I think that's just introductions. Yep.
Oh, yeah.
Yeah.
Okay. Yep, those bars make it look like this.
Yeah.
Yeah, well, and you know, I could just make this box bigger.
While they're looking for questions, one thing I did want to mention is, you know, in looking at juvenile services and looking at the numbers that have gone down One thing that's become even more stark is disproportionate representation of minority youth, particularly African American youth, in the more restrictive settings within our system. This has been an issue that has had ongoing attention in Maryland, and we've worked on it over the years, and now it's just become such a pressing issue for us, such a challenge, but something that we have to, as a system, work on together, because it is heartbreaking to look at, as the numbers are going down, as far as referrals and probation numbers are going down, and commitment numbers are going down, the disproportionate representation is still there, and even slightly more. And so, we're really trying to look at our system and how our DJS, what decision-making we are doing, and then looking at the whole system, all of the partners, including law enforcement, and how can we tackle this. Because we really have to look at the do no harm kind of thing, that are we reaching those kids that need to be reached at all levels, or are we allowing inequities to let kids be driven into the more restrictive settings and not addressing what they need. So that's a big area for us. That's a challenge, and the only way you can really start to address a challenge is to face it and be honest about it and make everybody look at it and break it down.
Thank you, Pat. We have another question. Tina Thomas wants to know if we have any free brochures to mail, specifically from the health department and local behavioral health, who work with youth and adult service coordination.
We have free brochures. No, but you can access the model website that was in this slide, and then we'll give you the contact numbers for each jurisdiction.
And we're all we're very strong advocates of electronic communication of this information, because the day it's printed is the day it's out of date. So the best thing that you can do is transmit that information electronically, and it provides an instant update when numbers change. But if there is something specific you're looking for, like I said, similarly to the program descriptions, just reach out to one of us, and we'll connect you with the right person and get you that information.
This is Caroline from BHA, all the programs that I had listed for the public mental health services, the descriptions are available on the Beacon website.
Okay.
The Beacon, Maryland. You can just Google Beacon Health Options, Maryland, and it'll take you straight to their website.
Yeah.
And you can navigate your way through children's services and have the descriptions of all those programs.
Thank you. And if I remember correctly, I think you linked their site on your slide. Okay.
And I guess I would add that evidence-based services that were discussed are described in our data resource guide, and the University of Maryland Institute for Innovation, their website has lots and lots of information about evidence-based interventions. It's interesting, we're looking at broadening how we look at effective programs and not just using the same small list of programs, looking at homegrown programs and what are the essential elements in those programs. So you'll see, I think, more and more of that information come out.
Thank you, Pat. Okay, so it looks like not many more questions, so I'm going to do a last call. If anyone has anything. Other than that, it looks like we are getting out of here 15 minutes early, which is mind-blowing because we had a lot of information to cram in that amount of time, so I'm very excited. But yeah, if anything comes to mind, if you're laying in bed tonight and you think, shoot, why didn't I ask that? Send over an email and we'll be happy to connect you to who has the right answers. So thank you for joining us today.
Thank you. Enjoyed it, everyone.
Thank you. Okay.